20 years ago, the first patients were treated with the CyberKnife system in Europe, and more precisely, here at the Hospital San Bortolo in Vicenza, Italy. I've asked 20 questions to the clinical team to celebrate the 20th anniversary of the CyberKnife technology installation. On behalf of Accuray, congratulations to the team for such a milestone. And now, let's hear from them.
I am Dr. Fornezza. I'm the director of CyberKnife Center in Vicenza. And I have my co-worker, Dr. Mary and Dr. Perini. We are very proud today to celebrate the 20th anniversary of the CyberKnife activity in our hospital.
Good morning, I'm Zeno Perini, I'm a medical doctor of the CyberKnife unit in Vicenza, and this year we are proud to present the 20 years anniversary in the use of the CyberKnife, and thanks to Professor Colombo to admit me here 11 years ago.
I'm very proud to be here today in name of AB Medica. We started this journey 20 years ago with the Vicenza Hospital team with the CyberKnife, this new technology that was very new for us and for them also. They are very happy today treating patients with this technology, and we hope to be their partner again and again in the years to come for many other years. Thank you very much, Vicenza.
A CyberKnife system was installed in our department on January 30, 2003. The rationale was to do away with the stereotactic fixed frame and made feasible both multi-session and extracranial radiosurgery. In 1982, Professor Colombo developed an original stereotactic device using a normal LINAC for the first radiosurgery treatment. He treated more than 1,200 patients with the radio ring and in a single shot. The procedure had proven to be effective, but with some limitations and drawbacks. In fact, large tumors or large AVMs cannot be treated owing to the increased risk of complication. We needed an innovative radiosurgery apparatus to fix these problems. CyberKnife image-guided radiosurgery afford significant improvement in procedure. CyberKnife system consists of a compact 6 megaelectron volt LINAC mounted on a robotic arms with 6 degrees of freedom, and the system requires no invasive rigid frame to immobilize the patients. It's designed to deliver the radiation beam to a region of space centered over 2 orthogonal X-ray imaging systems to provide image guidance to patient tracking. The non-isocentric radiation beam provides an highly conformality radiation. "20 years ago, we continued with the same indication as before with LINAC radiosurgery, but also in patients with larger lesions, intracranial AVNs, meningiomas, vestibular schwannomas, gliomas, metastases, but was possible to start treating patients with spinal tumors. The same pathologies, but with larger volume. During 20 years, we have performed more than 9,000 treatments for neurosurgical pathologies, intracranial and spinal treatments. The first patient was a young lady with a large cavernous sinus meningiomas with deficit of cranial palsy. The lesion was unsuitable for LINAC radiosurgery in single session, so we treated her in 5 sessions without complication, and we obtained a long-term growth control and a clinical stabilization. Professor Colombo has gave us an important scientific and human legacy with his immense neurosurgical and radiosurgical knowledge. He always sent us to attempt a meeting or congress for our scientific update. So he taught us how to perform a perfect treatment plan. He was one of the most important radiosurgeons in the world, a really pioneer, when in Italy nobody knew radiosurgery. Well, the clinical program included the treatment of trigeminal neuralgia, spinal tumors, recurrences of glioma, with the diagnostic improvement of MRI and CT PET. But a great improvement in the treatment of AVMs was due to the introduction of the three-dimensional angiography that allow us a perfect contour of AVMs needles, reducing side effects. The second CyberKnife was installed in August 23, 2011. The rationale was to increase the number of treatments both with the neurosurgical pathologies and for body pathologies from the colleagues of radiation oncology department. The treatments were faster and the dose distribution was improved. We always treat the same pathologies, but our effort is to treat especially patients with the large AVMs using volume stage strategies. We received pediatric patients from all over Italy, and we continue to treat acoustic schwannoma and meningioma, pituitary adenoma, with good results in case of large neuromas. The team today for neurosurgical pathology consists in 3 physicians, 4 radiology technicians, 2 nurses and 1 administrative person. Then there is a team of radiation oncologists of 4 physicians for body pathologies.
When you perform a treatment with CyberKnife, the patients have to wear a simple mask and a soft mask that is not invasive, and the patient have not anesthesia, so is awake and he knows in every moment what is happening around him. So for the patient, this is important, and this is important also that is a day hospital, a sort of day surgery. So patient come here, perform the treatment, and the evening he sleep in his bed. So it's very important because it's not in hospital. That is is not a good environment for a patient that have to face a pathology like a neurosurgical pathology. So this is the enormous advantage that, in my opinion, the CyberKnife gives to the patients and for the treatments of the patient and neurosurgical pathologies. I can say that I can observe an improvement of the interest of the patient in this kind of technology, because it's not invasive and it's permit to face the pathology with another spirit, with another intentions, and this is in some cases a good alternative to neurosurgery, to the operative room, and this is encouraging for the patient. So yes, I observe a lot of interest of the patient in these years in these techniques. I heard for the first time the CyberKnife system here in Vicenza in 2004, and I was a student in medicine, and I knew about Colombo and the CyberKnife system here, and I was fascinated. I was very interested in it. So when I was graduated and I start my experience like a resident neurosurgeon, I asked and I stressed my chief professor, Professor Dovella. I stressed him very much to ask him to come here in Vicenza to observe and to learn about the CyberKnife system by Colombo. And at the end of the 2011, my professor said, "Okay, Zeno, go to Vicenza. Please go to Vicenza." And at the beginning of the 2012, I was here in Vicenza, so it's 11 years that I'm here to use the CyberKnife. In the last years in particular, in the last 5 years, 6 years, I observe I'm more interested in this kind of techniques from my colleagues of physicians, in particular from oncologists, for example, but also from doctors of the territories that send us the patient for the neurosurgeon pathologists, and also from our colleagues neurosurgeons, yes. We perform in particular hypofractionation for pathologists, in particular for benign tumors, for example, benign pathologies like meningiomas, acoustic neuromas, pituitary adenomas, and also in malignant disease, for example in gliomas or in metastasis, we can perform some hypofractionation, in particular 3 or 5 fraction. We don't go over the 5 fraction normally for the treatments, for the hypofractionation treatment, because the CyberKnife was born in particular for hypofractionation and to use doses, high doses to perform the treatment, and also to treat large disease, large metastases or large tumors. So we perform in particular hypofractionation. But there are some cases, in particular the AVMs, where we perform a single fraction. In AVMs, for example, or in some kind of metastasis, that in particular if they are too small or particular small, we utilize the single fraction, because we observe that and the literature, the scientific literature is agree with us that is for some pathologies like AVMs is more useful a single fraction than hypofractionation. So we have a lot of patients that we treat in single fraction. Yes. Yes, we perform in particular hypofractionation for pathologists, in particular for benign tumors, for example, benign pathologies like meningiomas, acoustic neuromas, pituitary adenomas, and also in malignant disease, for example, in gliomas or in metastasis, we can perform some hypofractionation, in particular 3 or 5 fraction. We don't go over the 5 fraction normally for the treatments, for the hypofractionation treatment, because the CyberKnife was born in particular for hypofractionation and to use doses, high doses to perform the treatment, and also to treat large disease, large metastases or large tumors. So we perform in particular hypofractionation. But there are some cases, in particular the AVMs, where we perform a single fraction. In AVMs, for example, or in some kind of metastasis, that in particular if they are too small or particular small, we utilize the single fraction, because we observe and the literature, the scientific literature is agree with us that is for some pathologies like AVMs is more useful a single fraction than hypofractionation. So we have a lot of patients that we treat in single fraction. Yes. The clinical problem is not evolved so much. So because we perform a single fraction treatment for the AVMs, for example, 15 years ago, and we treat with single fraction 15 years then. Is evolved because our experience is evolved. Our experience to use it is evolved. And we understand, for example, that fractionation, for example, for I use an example for acoustic neuromas that where the patient have an anacusia, the patient has not usable hearing, but you can fractionate it because it's sparing for the brainstem, for example. And this is a particular experience that we have and we evolve. The indications for the treatments are not evolved so much. They are changed, yes, but I don't think they are evolved.
To colleagues interested in CyberKnife radiosurgery, I would like to say that this is a device that gives a great professional satisfaction. It's well tolerated and accepted by patient. It presents only rare side effects and is very effective in control growth of many intracranial lesions. Furthermore, it allows a high rate of complete obliteration of the AVM's nidus.
The clinical benefits are, in my opinion, are that the patient is motivated to face the pathology because the technique is not invasive, it's not particularly invasive, but is efficacy, is useful. This is a clinical important advantage because you don't have to recovery the patient's recoveries, you don't have the problem that the patient, the psychological problem that for a patient to stay in a hospital, and so the compliance for the treatment and to face the pathology is better than not in ordinary recovery. So for me this is a very important clinical benefit.